is E Barret from France, from Paris. He has his clinical expertise mainly in uro-oncology, in prostate cancer, minimal invasive surgery, and also in focal therapy, where he has published a lot of data. So we asked him to hold a lecture about what is considered state-of-the-art in 2019. And we are excited to hear your talk. Thanks for being here.
Thank you, Cedric. Thank you for the invitation. I'm very glad to give a talk to you today on my favorite topic, the focal therapy. This is my disclosure. So first, I would like to remind you that focal therapy was initially developed in order to limit the risk or to reduce the risk of side effects due to the radical treatment, either radical prostatectomy or irradiation. The first treatments were performed more than 10 years ago. We had a lot of a few trials regarding the subject, and we have now the data. That's probably why the EAU decided to publish its position last year in European Urology. And the conclusion of the article was that if the long-term benefit is proved, I mean, oncological and functional outcomes, focal therapy would represent a significant progress in prostate cancer care. So that's probably why it's important to be interested in this technique. However, the focal therapy is not yet a part of the guideline. It's not a part of the guidelines. Why? Because we don't have enough validated data, and due also to the multifocality of prostate cancer. And for the American guidelines, focal therapy, it's probably not the ideal treatment because we could probably not able to treat in one shot the prostate cancer. So, however, the focal therapy exists, but it still remains experimental. So you all know that when a man is diagnosed with prostate cancer, he has to face a Cornelian choice. According to the European guidelines, he has to choose between the active surveillance or an active treatment, but we know the complication occurred by the active treatment has incontinence or impotence. That is why there is maybe some rooms for something in between. It's exactly the same for the American guidelines, and if you look in greater details the recommendation, when a patient is diagnosed with a favorable intermediate risk, he has to choose in between radical prostatectomy or irradiation plus ADT, which is maybe a little bit too much, this is my opinion, and we have probably to take into consideration the specificity of each cancer and to adapt the treatment to the disease. You all know the PROTECT study, so we learned from the PROTECT study that whatever the treatment chosen for our patient, either monitoring, surgery, or irradiation, the mortality of prostate cancer is very low. However, it has been shown that when we treat prostate cancer, we decrease the risk of disease progression and metastasis. That is why a treatment could be indicated in some patients, even if they have a low or intermediate risk prostate cancer. However, we know that we increase the morbidity of treatment. So there is maybe a room for a potential new treatment option, which will offer a few complications, a shorter hospital stay, a faster recovery, and a lower overall cost. And apparently, focal therapy meets all these criteria. What is the definition of focal therapy? Focal therapy is defined as an ablative strategy that targets the dominant lesion or the index lesion. The objective of focal therapy are to maintain the oncological benefit of the active treatment, is to eradicate the clinically significant disease with the possibility of retreatment if needed, and to preserve as much functional tissue as possible, because this is the first aim of this treatment, to limit the risk of side effects. So if we want to do focal therapy, we have carefully to select a patient, because the selection of patient will I mean, the success of the treatment will probably depend on the patient selection. We have to clearly identify the true cancer, we have to target the lesion with precision, and we have to evaluate the treatment's effectiveness, and that's what I will try to explain. So first, how to select a patient. There are different factors to consider. The first one is the disease factor. A group of experts published a recommendation regarding the disease factors, and they consider that if initially the focal therapy was reserved for patients with low risk disease, the indication moved, and nowadays it's probably indicated more specifically for patients with intermediate prostate cancer. And the ideal patient is probably the patient with a small lesion, unique lesion, unilateral lesion with an intermediate risk of prostate cancer, lesion 7, 3+4. And in this paper, they consider that a low volume of low risk prostate cancer in the prostate is probably not necessary to be treated. The patient factors, so the patient need to have a good life expectancy. The first goal of this treatment is to preserve the sexual function, so this is some point important to take into consideration, but the lack of erectile function is not, that cannot exclude the patient for focal treatment. If the patient has mild low urinary tract symptoms, it's not a contraindication for focal therapy, but we have to take into consideration the prostate volume, especially depending on the energy that we will use for focal treatment, and I will explain to you why. So how to identify the true prostate cancer, MRI and prostate biopsy. We have seen this morning with Stacy the importance of the MRI in the detection of prostate cancer. So we know that MRI is probably the tool, only one tool that we have in order to better detect the prostate cancer, and the PROMISE studies provides a high level of evidence for assessments of diagnosis accuracy of prostate cancer with using multiparametric MRI. Indeed, the author shown the high sensitivity and the high negative predictive value of the multiparametric MRI, making this tool as triage test for the biopsy, but not only for the biopsy, probably also for the focal treatment. So nowadays, the guidelines consider the MRI to be performed right before the second series of biopsy in case of negative first series, but as Stacy said, the NICE UK recommend from December to perform MRI in first line before the first series of biopsy. We use the MRI for the detection of prostate cancer, but it could be also useful for the local staging, and but apparently it's not the best exam to use for the local staging because the poor and heterogeneous sensitivity for detection of extracapsular invasion, seminal vesicle invasion, and overall stage of T3. So if we want to have a better local staging with using MRI, it's recommended to use an endorectal coil or a high level or high field strength like T3, and the 1.5 Tesla is probably the ideal machine for evaluating the local staging. So we need to work with a radiologist, and it's very important to have a strong collaboration in between us. Why? Because they will give us the information regarding the prostate cancer, and they will help us to detect the prostate cancer while performing the biopsy. So how to perform the biopsy? For many years, we used the transrectal biopsy without any additional information, and right now we know that MRI is very important in order to guide the biopsy. So there are 3 ways of performing biopsy. You can do the biopsy in bore, but it's very expensive and it's probably not recommended anymore. But you can use the cognitive fusion biopsy, and you can use the software MRI ultrasound fusion biopsy. So what kind of biopsy do we have to perform? The 2 papers which are on this slide, the precision and the MRI first, try to answer to this question. We have seen the precision paper this morning, 500 patients randomized in 2 arms. One arm with standard biopsy, and in the second arm, the patient had, in case of targeted on an MRI, they have targeted biopsy. In the second paper, MRI first, 251 patients, all of them had the standard biopsy, and in case of targeted on the MRI, a second radiologist did the targeted biopsy. The conclusion is that in these 2 papers, for the first one, that the targeted biopsy is superior compared to the transrectal biopsy if we want to detect the clinically significant prostate cancer. And in MRI first, the difference in between the groups was not very important. However, they consider that the combination of the targeted and standard biopsy is probably the best option if we want to have a better diagnosis of prostate cancer. That is why we cannot do probably only just the targeted biopsy, but we have to add the standard biopsy in order to improve the diagnosis of prostate cancer. So we know what cancer to treat. The patient has been selected, so now what kind of focal therapy do we have to perform and which energy do we have to use? In fact, the definition of focal therapy is not, of how to perform focal therapy is not very well established. So we know that the focal therapy consists in applying a certain amount of energy to the tissue, to the target, enough to destroy the tissue, but not much if we want to spare the surrounding tissue. So there are 2 way of doing which has been described: the targeted ablation, the hemiablation, or the zonal ablation, which is a subtotal ablation. So we consider that if we want to spare the maximum of tissue, the first option, the targeted ablation, is probably the most adapted treatment modality. However, we know that the MRI underestimated the size of the lesion, so it's important to take safety margin when we perform the treatment. Around 9 millimeter, this is under discussion. We don't know exactly how many millimeter, and it's probably very difficult to define, but we need to treat larger than what the MRI said. What energy to use? There are a lot of energies available on the market. Massimo Valerio published this paper in 2017 trying to define what energy is suitable for focal treatment. In fact, he described 7 energy sources used for focal treatment. The 7 energy sources are HIFU, cryotherapy, brachytherapy, vascular targeted photodynamic therapy, laser interstitial thermal therapy, irreversible electroporation, and radiofrequency. Honestly, the 2 most experimented energies are HIFU and cryotherapy, and I will try to give you more details regarding these 2 energies that we can use in routine in our institution. Regarding HIFU, different way of delivering HIFU. There are different machines, several machines on the market. EDAP and Sonocare can be used for a transrectal approach under ultrasound guidance. Inside, it developed a machine, an inboard HIFU machine, and Profound Medical developed a transurethral HIFU system. What is the principle of HIFU? When we do HIFU, we use a transrectal probe, which is a combination of a transrectal ultrasound for scanning the prostate and a piezoelectric transducer. The piezoelectric transducer will generate a beam which will focus at some point, the focal point, and at that point there is an increased temperature around 70 degrees, which will generate irreversible necrosis. A lot of publication regarding HIFU. If you look at this data, the control biopsy regarding the ontological control, the control biopsy after 1 year are pretty interesting because the between 75 to 85% of the patient had negative biopsy at 1 year, and the treatment has very low impact on the erectile function and continence. Regarding cryotherapy, it's a transperineal approach. So two systems on the market, the Undercare system and the Galil system. So the principle is to use this transperineal approach. The patient is placed in the gynecologist position under general anesthesia, and we place the needle under ultrasound guidance within the prostate, within the prostatic parenchyma, according to treatment planning that we perform in order to cover the suspected lesion. So the principle is to use a high pressure argon gas, which when it flows through the needle, which generate at the tip of the needle a ice ball, and with this very cold temperature, we will create an irreversible necrosis of the tissue. Results, they are pretty the same, you know, good control, good ontological control, and very low impact on the continence and the potency. Very few data regarding the other energies, brachy, laser, irreversible electroporation, everything is under evaluation. There are a lot of trials regarding this technique. I just wanted to point the last one, the VTP technique, because this is the only one phase 3 trial that had been published in the literature regarding the focal therapy. In this paper, the author compared two groups of patients. 200 patients received VTP treatment, and 200 patients had were in active surveillance. And the conclusion of the paper is that the focal treatment could limit the risk of effective treatment for localized prostate cancer. That means that if you look at the results, the progression in the VTP group was significantly lower than in the active surveillance group. However, the criteria of evaluation were very, strange, because they didn't consider negative biopsy in the treated area. They considered the patient, the failure when the patient had more aggressive disease than the initial disease. And if you look at the rate of negative biopsy at the end, you see that in the VTP group, 50% of the patients had positive biopsy. So is it a good treatment? So maybe not, but we have to still to evaluate this technology, and maybe to change a little bit the criteria of inclusion, because this study was designed more than 10 years ago. So we have now to compare this treatment with probably the standard, which is the standard of active treatment, which is maybe the radical prostatectomy. So to summarize the energy sources, if you look at the paper of Massimo Valerio, the follow-up is limited, 4 months to 61 months in the literature. Very few adverse events, serious adverse events, very low impact on continence and potency. And regarding the ontological control, pretty interesting results, because around 90% of the patient had negative biopsy for clinically significant disease after 1 year. So the results are pretty good, but this is just after 1 year. We need to further improve this technique if we want to make the focal therapy a great treatment options. How to improve the treatment? Probably while using the MRI guidance. We can use it when we have a transrectal approach with ultrasound, because the focal one machine allows to perform the treatment under MRI ultrasound guidance, fusion guidance. And regarding the what I would call the needle therapy, all the therapy which has been delivered with using the needle, we can now use all the platform which are dedicated to the MRI fusion biopsy. All of them offer the possibility of performing the focal treatment. If we want to further improve the results of focal therapy, we have also to take into consideration the limitations of the energy. HIFU is a great treatment, HIFU is a great machine, but it doesn't work for the anterior lesion. If you try to do necrosis, a suspended necrosis at the anterior part of machine, whatever the volume or the size of the prostate, it doesn't work. So it's not recommended to treat the anterior lesion with using HIFU. And the second limitation of HIFU, as you know, is it's based on the very high temperature and the diffusion of very high temperature. And if you treat a lesion, an apical lesion, there is a risk of heat diffusion to the sphincteroid muscle, and the patient become incontinent. So it's not a good option for apical lesion. Regarding cryo is a very good treatment option. However, if you want to kill the tissue, you have to reach an isotherm of around minus 20 degrees at the level of the prostatic parenchyma. And if you treat the posterior lesion, and you know that the edge at the edge of the highest ball, the temperature is around 0 degrees. So if you treat a posterior lesion next to the neurovascular bundles, you start to damage the nerve at 3 to 5 degrees. So it's probably not recommended if you want to spur the sexual function to the patient. It's probably not recommended to treat this kind of lesion with using cryo. When we do cryo, if we want to keep the continence to the patient, we systematically use a warmer, and the warmer will warm the tissue around the urethra, and more specifically around the sphincteroid muscle, but around the urethra. So it's not recommended also to treat patients with apical lesion, because you warm the apex with using cryo. The warmer, you warm the apex, so it's not. This is the area where we have the most of the recurrences, so it's probably not a good indication for cryo. And brachy, which is another option that urologists use. We know that if we place the seeds very close to the trigona or urethra or rectum, we increase the risk of toxicity. And probably that's a paper that we published 2 years ago, that the best indication for focal brachytherapy is probably the apical lesion, because surprisingly we compare the side effect between the patient who had an implantation at the base and at the apex, and we have a significant difference in terms of irritative symptoms after brachytherapy, without any symptom, without a side effect in the group of patients who had an implantation at the apex. So, according to all of this limitation, and so we describe in my institution the a la carte approach, and that's what we do in my institution. We usually treat patients with posterior lesion with using the HIFU, the apical lesion with using the brachytherapy, and the anterior lesion with using the needle therapy, either cryotherapy, electroporation, or whatever. So the patient has been treated, so now we need to evaluate the effectiveness of treatment. You know all these tools that we use for all the prostate cancer evaluation, PAC, MRI, control biopsy, validated questionnaire, because we need to evaluate the oncological control and the functional outcomes. We know that the PAC is probably not a good tool for the focal therapy evaluation, because a large part of prostatic parenchyma remains intact, so it's not a good. We will not have any information from the PAC. So the two exams we have to use for the post-focal therapy evaluation are MRI and control biopsy. Again, it's control biopsy. When we do control biopsy, we have to do MRI first and then guided biopsy. This is the recommendation published by Müller from the expert group. They recommend after focal therapy to do a PAC test every 3 months during the first year, an MRI after 6 months or 1 year, and then a biopsy guided on the findings of the MRI. And then during the following years, a PAC every 6 months, an MRI every year, and biopsy just in case of suspicion of recurrence on the MRI, or in case of increasing, or if the patient has a significant increase of PSA. Another issue with focal therapy is how to define the failure. You know, what is a failure after focal therapy? This is a big issue, a big subject of discussion. Theoretically, from my point of view, a success is a non-residual disease in the treatment area. But apparently, there are different groups try to define what a success is, and recently the Tom Polachik group published a paper explaining that the success is defined as no residual disease in the targeted area, but we can also accept a small volume of Gleason C or a very small volume of Gleason 7 3+4 as a success. Well, I don't know what is a very small volume of 3+4 on the biopsy and the MRI, so we don't know. The problem is the contralateral lobe or the rest of the prostatic parenchyma. If we have a positive biopsy at the control biopsy after 1 year, we cannot consider the positive biopsy as a failure, but it's probably a misdiagnosis at the entrance biopsy. And it's something which is very important to highlight is that negative biopsy after 1 year doesn't mean that your patient has been cured, and it's very important to continue the follow-up. How to manage the failure after focal treatment. Usually people say that salvage treatment after HIFU or after cryo is very difficult, but it's totally difficult depending on the energy that you apply to the gland. And if you apply a very small amount of energy, honestly, it's totally different than when we do a whole gland treatment. Whatever the treatment you will choose, it's very important to precisely analyze the reasons of the failure, because if you treat an anterior lesion with using HIFU, if you have a failure and if you do another treatment and another treatment, you can continue many times and it will not work. So it's sometimes important to change, to move for another energy if you want to succeed the treatment. The other point which was initially discussed was focal therapy is maybe not, in case of failure, we can maybe not retreat the patient, and now we know now that the answer is yes, focal therapy can be redo. We can do many focal treatment in the same gland. It has been published in different papers. So how to manage the failure? We consider that if we have a very low volume, it's in fact like a naive patient. If you have a low volume of low-risk prostate cancer, you will offer him an active surveillance. If you have a low volume or intermediate volume of intermediate risk of prostate cancer, very localized recurrence, you will offer him a focal salvage treatment. And if you have a more aggressive disease, you will offer the radical treatment. What kind of radical treatment? You can do, of course, in irradiation, and the question was, is radical prostatectomy feasible after focal treatment? And the answer is yes. We published a series last year in Journal of Urology. We compared two groups of patients, the group of patients who had radical prostatectomy after focal therapy failure, and a group of patients with the same disease characteristic and without any previous treatment. And in fact, we don't have we don't reported any differences in terms of peri or post-operative complication. We had the same results regarding incontinence, but we have worse results regarding erectile function. And in case of biochemical recurrence, the biochemical recurrence was earlier in the group of patients who had a former focal therapy, but it's probably because most of the time we had an under-evaluation of the disease, and the disease was more aggressive than what we expected. The conclusion is that, my conclusion is that focal therapy aims to ablate the significant localized prostate cancer, but still experimental technique. Several treatment options are currently investigated for focal therapy. The improved performance of imaging have to help us to improve the results of focal treatment. The success of focal therapy will depend on the ability of identifying and targeting the lesion. And we need to develop clinical trial in order to better evaluate this treatment and maybe to push this treatment and to include this treatment within the guidelines. And I would like to suggest you a new paradigm for the prostate cancer management in 2009 and 19. Active surveillance for low volume, low risk prostate cancer, radical treatment for the most aggressive disease, and in between we have to develop this focal therapy, which is probably a good thing for a patient because due to the low impact on the functional outcomes. Thank you very much.